Welcome. This session provides a technical deep dive into the NHSN framework for surgical site infection surveillance, specifically designed for clinical microbiologists and MD postgraduates. We will explore how to move from clinical diagnosis to objective, standardized epidemiological reporting. Clinical diagnosis versus surveillance. Surveillance requires a fundamental shift in mindset. While clinical diagnosis is subjective and patient-focused for treatment, NHSN surveillance is highly objective. We use strict definitions to ensure interinstitutional comparisons and consistent baseline risk adjustment, regardless of who is collecting the data. Anatomical classification. Classification follows the maximum depth of tissue involved. Superficial incisional involves only skin and subcutaneous tissue. Deep incisional reaches fascial and muscle layers. Organ space includes any part of the body deeper than the fascia that was manipulated during surgery. The temporal framework, 30 versus 90 days. The surveillance window depends entirely on the procedure. Standard procedures like appendectomies or cholecystectomies require a 30-day window. However, high-risk procedures involving implants, breast surgery, or cardiac tissues require an extended 90-day follow-up. Wound classification. Every procedure is categorized by contamination levels. Class 1, clean wounds, have an expected infection rate under 2%. Conversely, Class 4 dirty infected wounds, such as those involving perforated viscera, have a high baseline risk of 20 to 40%, which must be factored into our benchmarking. The SSI rule breakers. No IWP RIT. Crucially, SSI surveillance breaks the standard rules for device-associated infections. Because SSIs can manifest post-discharge, the rigid 7-day infection window period and 14-day repeat infection timeframe are explicitly ignored. The criteria remain entirely relational to the procedure date. PATOS, infection present at time of surgery, identifies infections such as an abscess or ruptured appendix, noted intraoperatively. While these are still reported as SSIs if they meet criteria, marking them PATOS equals yes allows for critical risk adjustment of the facility's baseline data. To differentiate a primary CLABSI from a secondary event, we use a strict 17-day SBAP. If a blood culture matches the SSI pathogen within 3 days before to 13 days after the date of event, the bloodstream infection is attributed to the surgical site. Effective surveillance must be active and prospective. While ante-discharge review of medical records is standard, the primary challenge is post-discharge surveillance. Most SSIs manifest after the patient leaves, requiring active surgeon or patient surveys to avoid false negative reporting. Prevention is structured into 3 phases. Preoperative care focuses on chlorhexidine bathing and hair removal via clippers only. Perioperative care emphasizes normothermia and glucose control, while postoperative care mandates strict aseptic non-touch technique for wound management. Raw SSI rates fail as a comparison tool because they don't adjust for patient risk or wound class. Instead, we use the Standardized Infection Ratio, SIR. An SIR greater than 1.0 indicates more observed infections than predicted based on national baseline data. In summary, every event passes through this funnel. We establish the denominator, verify the temporal window, determine the anatomical depth, and apply specific rule-breaker logic like PATOS. This ensures our final data is ready for standardized national reporting.